Now we'll move on to our keynote presentations. I am very excited and grateful to have Drs. Hafastou, who we call Fifi, Diop, and Dr. Munish Gupta joining us virtually today. Dr. Diop is the Director of Office of Data Translation and also the Principal Investigator of the Perinatal Neonatal Quality Improvement Network of Massachusetts. She'll be talking to us about early intervention enrollment among infants with NAS. Dr. Gupta is the Quality Improvement Director at the Department of Neonatology, Beth Israel Deaconess Medical Center in Boston. And he'll be sharing work around improving neonatal abstinence syndrome. Can PQCs move beyond the basics? And I'm thrilled to have them here because it is really only with their help and guidance that CHoSEN Quick was even able to get started. And so I'm not sure if Munish is even aware of this, but Munish got us started over 3 years ago at the very first CHoSEN Quick forum when we weren't even called CHoSEN Quick. We were just like helping babies with NAS, some lame kind of group name. And Munish came to our very first meeting and shared with us what Massachusetts was doing and really helped us get started. And if you notice in our mission statement, our aim is copied actually directly from Massachusetts. So on so many levels, it's really been the expertise and the guidance from the Massachusetts Perinatal Quality Collaborative that's allowed us to move forward. So thank you so much. So I'm going to hand it over to Fifi first. So I'm going to stop screen sharing so that our Massachusetts team can share their own screens.
I think they were supposed to share my slides.
Yes, Jillian, I think is working on sharing slides for you.
Okay, thank you.
Absolutely.
Can you hear me okay?
Yes, you sound great.
Awesome. Okay. Thank you so much, Susan, for that introduction. We can't wait to get you back in Massachusetts. We always bring people back when they leave. Thank you for this opportunity to describe the work we've been doing here in Massachusetts. Next slide. I have no conflict of interest. Next slide. I want to provide a little bit of background about our state before I start. Like the rest of the country, Massachusetts has been hard hit by the opioid epidemic, and every single community in the Commonwealth of Massachusetts has been affected, with a 350% increase in opioid-related deaths since 2000. And at the same time, just between 2012 and 2016, opioid death rate tripled, going from 11.2 to 32.2. And we are also seeing that pregnancy-associated deaths are, due to substance misuse, are increasing. Next slide. Between 2005 and 2014, as you can see, we saw an alarming increase in pregnancy-associated death, going from 8.7% to 41%. Next slide. Similarly, we saw an increase of NAS. In 2011, we had a rate of 11.2, and soon enough, in 2015, we had a rate of 14.4. This was alarming in our state, so the Governor Patrick Deval, declared a public health emergency and directed the Massachusetts Department of Public Health, MDPH, to take action. And as a result, an opioid task force was created. And subsequently, Governor Baker signed into law Chapter 55 of the Act of 2015 to permit linkages and analysis of all available state data to guide decision making. We were able to link 15 statewide data sets. This was unprecedented because it allowed us to bypass a lot of the legal barriers to data linkages. Next slide. Shown here are our NAS rates for 20 hospitals in 2015. And as you can see, some of these hospitals had rates that were higher than 20%. The overall 20 times higher than the national average. The statewide rate for NAS in Massachusetts in 2015 was 5 times higher than the national average. But for some of these hospitals, it was 20 times higher. We found it to be very challenging to have half of our hospitals having 17 per thousand rates, which was extremely high. And these data were used to determine which hospital to focus on for early intervention or other programming. Next slide. So in 2017, when we applied for our CDC grant, we intentionally focused on addressing perinatal opioid use using a life course model by targeting outcomes during 3 key periods. During pregnancy, focusing on improving care among women with OUD, primarily measured by the % of women with OUD who were receiving medication-assisted treatment while pregnant. At the time of delivery, focusing on improving breastfeeding for substance-exposed newborn, measured by the % of SCN receiving mother's own milk at the time of hospital discharge. And in the first year of life, increasing enrollment of infant with NAS in early intervention services. My goal for this presentation is to highlight some of the strategies we've been using in Massachusetts to improve early intervention enrollment with NAS and SCN. Next slide. A little bit about early intervention. In case you're not familiar with it, I see some names from your Title V. Jamie, I'm sure, knows a lot about EI. But early intervention is collected under Part C of the Individuals with Disability Act of 1997. In Massachusetts, early intervention data are collected and housed at the Mass Department of Public Health. EI services are provided at no cost to infant and children ages 0 to 3 at risk for or established developmental delays due to birth, social, emotional, and or environmental factors. Next slide. There are 4 categories of eligibility for EI. Many of these child and family eligibility characteristics are recognizable at the time of birth and are recorded on the birth or delivery hospitalization record. These include infants and toddlers with an established condition or conditions, infants and toddlers with an established developmental delay or delays, infant and toddlers at risk for developmental delays. And the last category is clinical judgment, which is a very broad category, and we enroll a fair number of children under this category, as Massachusetts has a very robust EI program with over $170 million a year. Next slide. Over the past decade, we have added additional eligibility categories. In 2009, beginning 2009, NAS became an automatic qualifying diagnosis for EI services in Massachusetts. As such, infants with NAS may receive services up to 1 year of age at no cost. Other categories include parental substance use, SCN, and siblings with NAS or SCN. However, for these categories, there is an additional requirement, including family characteristics and or at least 3 other eligibility factors or developmental delays. Next slide. Next slide. A question I frequently get from our clinicians is, why is it so important to focus on EI? Well, for one thing, we don't know much about what happens to these infants when they go home. Only a few studies have shown that infants with NAS are at increased risk for developmental delays and later behavioral, educational, and mental health problems. So in Massachusetts, we've been using early intervention services as a way of improving post-discharge care among infants with NAS across the state regardless of geography and ability to pay. Bottom line is there is a little bit of a knowledge gap. And if we are able to enroll all infants with NAS in EI, we could learn a great deal, and we would fill in a knowledge gap between 0 and 3 at the population level, because EI is a statewide program. In addition, EI services can be used to support parent-child relationship and connect women with OUD with other services they may need that are available in their communities, such as breastfeeding programs, peer mentoring, and home visiting, etc. Next slide. EI services have been also used to support healthy parenting among women with OUD by helping mothers with OUD improve their ability to take care of their children without feeling guilty or hopeless. We heard from moms that EI providers help them comfort, identify, and respond to baby cues. This is extremely important when dealing with moms with OUD who are also first-time moms or teen moms or foster moms taking care of babies with NAS or SCN. We also heard that sometimes all EI staff do is just to provide a reassurance that they are just there to help. Moms said, some of the moms, we heard from moms that as opposed to giving them the benefit of EI through the literature, what is known in the literature, they felt like the EI provider just being there and saying, I am here to help, tell me what I can do to help was enough. Next slide. So I'm going to shift gears here a little bit to share some of our data. You will hear more about this in the next talk with Munish. But this is from our statewide REDCap database, and shown here is the overall rates of EI referrals at the time of discharge. As you can see, we did not improve much between 2017 and June 2020, because we started at a 70% rate, which is pretty high. Next slide. And here is shown are the rates among hospitals participating, with a median of 72.2 at baseline in 2017 when we started the project, and which increased to 76.3 in 2019. Next slide. This slide shows rates for the entire study period, starting in 2017 through August 2020. And the overall median is at 76.6, which is not too bad. Next slide. Here is an example of how we've tracked the performance over time for one single hospital. And again, you will hear more about the data with the next presentation. Next slide. Now, while infants with NAS are automatically eligible to receive EI services in the first year of life, there are a lot of challenges to make that happen. These include parental factors, such as the belief that EI is for children with developmental delays, not their child who is opioid exposed newborn, or parent questioning what is the benefit of EI. There is also perceived and real stigma among EI providers against parents with SUD in general, which we've been working on changing through a lot of bias stigma trainings. There is a complete lack of trust and fear of losing custody to child protective services, immigration status, and other benefits some of these women rely on. Since EI services are home-based and providers visit women in their homes, some of these women view EI visit as a violation of their privacy, depending on their cultures. And sometimes women are just emotionally, socially drained and overwhelmed, particularly in the early postpartum period, and they just don't want to be bothered. They don't want people coming to their homes. Next slide. Other challenges include to early intervention enrollment include hospital factors and provider factors. There is hesitation within hospitals to focus quality improvement effort on post-discharge services because inpatient providers view these services as out of their control. Second, often NAS diagnosis is not provided to early intervention programs, which makes it impossible for the EI staff to evaluate and enroll them. The diagnosis of NAS must be provided in order for evaluation to happen. Also, a fair number of our children with NAS and SEN end up in foster care and moving from one geographic location to another, which makes it difficult for follow-up. Tracking EI enrollment is impossible for hospitals. Hospitals cannot do that on their own because of the inability to link their data timely with the EI participation data. In addition, despite the fact that QI does not require IRB approval, there are some privacy concerns, and most hospitals are required to go through full IRB to link their data. As more care for opioid-exposed newborn is provided outside the NICU, i.e. newborn nurseries or general pediatric wards, more education is needed for hospital staff about EI. NICUs are typically more familiar with EI benefits and eligibility. Next slide. So to support hospitals that were interested in tracking early intervention among their infants with NAS, MDPH conducted EI pilot studies in a few hospitals where we linked data, hospital data with EI participation data and returned a linked data set to the hospital. Some of these hospitals use their findings to inform their PDHC cycles. MDPH determined that this project is a program improvement and did not meet the definition of human subject research according to federal regulations and did not require review by IRB, which made it easier to do the linkage. We also conducted several EI workshops at our PinQueen Summit, all our PinQueen Summits, where hospitals and EI providers and families who received services, EI services, came together to discuss strategies and best practices to improve referral and enrollment among NAS and SEN. We conducted a full day workshop with hospitals and EI and Head Start providers, which was well received by all three group stakeholders. One important aspect of these workshops was having EI family members present and share their perspectives on what they thought were the most effective ways to engage families and what they felt were factors that could potentially turn families away. Next slide. The data shown here are from our NAS dashboard. As I mentioned earlier, in 2014, we were directed by the governor to create an opioid task force. One of the recommendations of the opioid task force was the development of a statewide NAS dashboard. The dashboard allows us to capture referral at different points in times, as well as evaluation, enrollment rate, and service durations. We are also able to capture readmissions among infants with NAS using the dashboard. Similar data were presented for hospitals' participation in the EI project. Next slide. This slide shows our statewide referral rates among infant diagnosed with NAS by race ethnicity. As you can see, Black non-Hispanic are less likely to be referred in the first 6 months compared to white non-Hispanic. Next slide. This slide shows our evaluation rates. And here we see that Hispanics have the lowest percent of being evaluated before the first birthday. By race ethnicity, they have the lowest rate. Next slide. And this one is the enrollment rates by race ethnicity at 12 months of between 0 and 12 months. While it seems like Black do better, the differences were not statistically significant, and actually the N for the Blacks was very small. Next slide. Before I end, I wanted to share what we've been doing at the Mass DPH to address inequities in health outcomes. Massachusetts is consistently among the 10 healthiest states in the country, but underneath that accomplishment, we know that there are racial and ethnic health inequities, and they have persisted for decades despite our efforts to improve outcomes. Shown here is our so-called DPH house, which provides a framework for our programs based on 3 key strategies: data, determinants, and disparities. We aim to provide timely access to data to reduce disparities and improve outcomes, address the social determinants of health which contribute to the health inequities, and eliminate institutional and structural racism in all our programs. Next slide. So for the past 18 months, the cross-bureau collaborative at the Mass Department of Public Health, including staff from Title V, the Office of Health Equity, and the Office of Program Management Quality Improvement, convened to create a racial equity data roadmap. This was done in response to a need identified by staff and programs around the lack of capacity to collect and use data for explicit action to promote racial equity. So the roadmap was developed by MDPH, one, to improve use of data for action to promote racial equity in MDPH funded programs, initiatives, including hospitals. 2, to provide suggested methodology to assess progress in addressing racial inequities in service delivery and health outcomes. And 3, collect guiding questions, tools, and resources that can be customized to best suit the needs of programs with different levels of capacity in data. This slide shows an overview of the different steps along the roadmap. As you can see, it's separated in 7 sections. 1, applying a racial equity reframe. 2, assessing program readiness to use a racial equity data reframe. 3, disaggregating data and assessing for inequities. 4, contextualizing data. 5, prioritizing strategies. 6, developing an equity spotlight to highlight the data. And 7, moving from data to action. The idea here is that there are multiple entry points to the roadmap, so different programs and institutions may start at different places. We have piloted different sections of the roadmap using our home visiting programs. The roadmap will be presented at our next PQCs Summit next month, with the hope that providers can use it at their respective institutions as a tool to address racial inequities. Next slide. Thank you.
Great, thank you so much, Fifi. We will take questions at the end of this keynote session. I just want to say that the phrase translating data into action is absolutely personified by Fifi, who I've known for about nearly 15 years, and truly her being the director of Office of Data Translation is absolutely the perfect title for her. Thank you, Fifi. Let's move on to Munish. I'll let you take over from here, Munish.
Sorry. Great. Thank you. I'm going to share my slides myself. Can you see them?
Yes, we can.
All right. Terrific. Yeah. Hey, thank you so much for the invite. Susan, too funny about the meeting a few years ago. And like Fifi said, we are working on getting Susan back. It'll happen at some point in the hopefully not too far future. I feel like Massachusetts and Colorado has partnered on this work for quite some time, because although we might have started it a little bit before you did, you guys caught up very quickly, and we've been working on similar goals throughout. So the back and forth over the past several years has been super helpful, both for our NAS work and also for our PQCs in general. We've had a number of conversations with your larger Colorado PQC team that have been super helpful. So for my next 15, 20 minutes, I'm going to try to build upon what Fifi spoke about and some of the themes that Susan mentioned in her intro as well, to get at this idea of what can PQCs do around a neonatal abstinence syndrome, neonatal opioid withdrawal syndrome, that goes beyond what we've done already. So can we move beyond the basics? We've already done some good work, some important work, made some real measurable improvements. But what's next? Fifi kind of got into this with the EI work, showing you some of the things we're trying to do in the early intervention space. And then that's important. But as she said, it's still kind of pilot work. And what else can we do there and in other areas? All right. Here we go. So disclosures, I have no relevant financial disclosures. I am going to share some work from Massachusetts, and just to acknowledge, it represents the work of a big team. There's a lot of people here working on our state collaborative, as well as people outside of our state collaborative who've been working real hard for a long, long time to improve the way we care for mothers with opioid use disorder and their families. Other hospitals and states, much like Colorado, have really done terrific work in this area. So I'm going to focus on some of the stuff, Massachusetts stuff. I'll try to highlight a little bit what some other states have done too. And unfortunately, a lot of this is going to be do what I say and not what I do, because when I'm talking about what are things PQCs can do beyond the basics, unfortunately, they are hard. And while we're working on them in Massachusetts, I can't say that we've made a ton of progress. So I'm going to suggest things that we can maybe explore together, both Massachusetts, Colorado, and other states. But I don't really have answers or good kind of examples of how to kind of go beyond the basics just yet. As Fifi said, in Massachusetts, we're trying to take this life course approach, very similar to what you guys have done in Colorado. I just organized it a little differently here. But in pregnancy, our goals: identify mothers with opioid use disorder, make sure they're in treatment. That includes MAT. On the newborn side, strive for family-centered care while the families are in the hospital, including rooming in and non-farm care. And then post-discharge, improve support and follow-up after discharge. Like Fifi said, our main focus there has been enrollment in EI. So I'm gonna kind of frame my talk in a number of claims. So claim one, I think PQCs have done quite a bit to improve the hospital-based care of the opioid-exposed newborn. So on my previous slide and in Fifi's slide, that's the middle one, right? So the newborn period. And it seems like this is what I would call the basics now. Here's where we've made a lot of progress. And Susan already shared some of your data, so I'm not going to share it again, or I will show it to you real quick. But I was going to use your collaborative as the best example of this. You saw some real improvements in farm therapy across your whole collaborative. Susan showed some updated data at the intro. You saw some real improvements in length of stay. This is kind of similar to what Massachusetts has seen. Your improvements have been a little more dramatic, maybe, in terms of amount of improvement. What you guys have shown, which other collaboratives have not shown, at least not yet, is you've also shown a reduced length of stay, even if farm therapy is required. In Massachusetts, this number is pretty flat, that once babies start on farm therapy, the length of stay hasn't gone down much. So our reduction in length of stay is because less babies are needing farm therapy. So this is impressive. This might be related to the kind of fact that you adopted PRN dosing pretty early on, whereas for us, that's still a relatively new intervention. I did want to show you one slide from Massachusetts. Alicia Walkman, who many of you may know, she's kind of one of the national leaders on Eat, Sleep, Console, along with folks from Yale and folks from Dartmouth. They put together resources that lots of folks are using. She published our ESC experience at the collaborative level just a couple months ago. But what she did was just pretty interesting. Since the hospitals in the collaborative implemented ESC at different times, what they did was they anchored this control chart to the time of ESC implementation. So the x-axis is not a time, it's everyone's ESC start was aligned, and then we work backwards and forwards. Hopefully that makes sense. So it kind of lets us compare impact of ESC across multiple hospitals, even though ESC was implemented at different times. And the reason I put this up is twofold. One, to kind of highlight that as a cool way of looking at this data, but also this is farm therapy, percent of opioid-exposed newborns needing farm therapy. you can see that the improvement really did seem to start a quarter or two before actual ESC implementation. And this pattern has been shown in a number of publications where if you define the actual implementation of ESC as a transition to that scoring tool, a lot of the improvements are seen beforehand, which if you think about it, makes sense, because before you go to the ESC scoring tool, you need to be doing rooming in, you need to be working on cuddlers, you need to be working on breastfeeding policies. So a lot of those other non-farm ideas people are working on to set the stage for ESC. And at the end, maybe it's those things that are most important rather than the actual tool you use to decide whether or not to start farm therapy. All right, so that's claim one. Claim two, so although we've done a lot to improve hospital-based care, there's still probably quite a bit more that we can do to improve hospital-based care. You know, a lot of the improvement work in Colorado and Massachusetts and other states has focused on non-farm care, which is terrific, right? And whether or not that includes ESC, non-farm care does include rooming in, family-friendly policies around breastfeeding, family-centered care. All of these are critical improvements, right? So where else can we take that kind of work for hospital-based care? I'm gonna give you two examples from hospitals in Massachusetts where they're looking at even more innovative ways of measuring family involvement. So this was a paper from Boston Medical Center, that's where Dr. Walkman is. This was actually a resident project where they looked at, they measured parental presence every shift, or I think every 4 hours. They documented whether or not the parents were in the room, and they looked at over the whole hospitalization, what % of time were the parents present. And they showed pretty convincingly, the more the parents were present over the whole hospitalization, the better the outcomes. The less length of stay, the lower the mean NAS score. This was back when they were using the Finnegan, the less total morphine needed, and the less days of opioid therapy. So pretty convincing evidence that the more parents are present, the better that the babies do. I mean, it's not rocket science. We got to know this now, but still good to show it. But can this be converted to a measure that can be used for improvement? So that's what the UMass folks did. That they made a measure where they started tracking non-clinical human contact for infants at risk of NAS. So every shift, or I think this is every 6 hours, they looked at how often was the baby getting contact with a parent or cuddler. And they're tracking this over time. Most of their parent improvements have been around cuddler improvement, but now they're working on improving the ability of families to be present as well. Obviously, there's things that limit families' ability to be present in the hospital for a prolonged stay, but it's a pretty cool measure that might be useful for collaboratives as well. What else? So Ohio has done some pretty innovative work looking at in-hospital care of newborns. They've been kind of doing NAS improvement work for quite some time. Many of the early collaborative publications around NAS work came from Ohio. So the most recent one, which just came out this month. So they used a technique called orchestrated testing. So within the context of their state collaborative, they had multiple hospitals working on improving the care of babies with NAS, the in-hospital care. And they recognized that hospitals were doing somewhat different things. So they had this idea that they could use that as a way of examining different interventions. And in particular here, they looked at formula type. So what they did was they divided their centers, all of whom were involved in the collaborative, into 4 groups based upon their current or their preferred use of formula. So they said their 2 choices were either low lactose or regular lactose formula, and then high calorie or regular calorie formula as your default kind of formula supplementation when needed. And based on this, they divided these hospitals into 4 groups, and they were able to see the impact of these different formula choices on outcomes. I'm actually not going to show you the results because, to be honest, I think a lot of us are not really focusing on formula anymore for these families. Our improvement strategies are really around breast milk use. But I think this idea of using a collaborative to do more structured analyses, including this orchestrated testing approach, is something a lot of us could think about to learn even more as we continue this work within our state collaboratives. I'll mention one other potential kind of tool around in-hospital care that we're exploring in Massachusetts. I think a lot of us have done a lot of work around kind of staff education and changing attitudes. We're trying to measure it if we can. we didn't think of this until this year or last year. We should have done this like 5 years ago. But we put together this a staff survey that tries to measure attitudes, knowledge, and skills. We did a literature review, some pilot testing to come up with the survey. Now we have this tool. It's about 10 hospitals used it last year. And these are the types of reports that the hospitals get back. This is just a subset of the questions, although there's not that many questions. This is attitudes. So the questions ask, to ask your staff to acknowledge, to express their agreement with these statements. And let's look at one. So I believe that mothers with OUD deserve the same level of health care as mothers without substance use disorder. The dark blue is strongly agree, and it goes from there. And you can see that most of the moms, most people agree, which is great. Similarly, I find I'm sympathetic towards infants with NAS. Almost everyone agrees. Here's interesting. I find that I'm sympathetic towards mothers with OUD. So a little less so, right? A little less so. So are there opportunities for education, for discussion, for conversations that might help move some of these measures over to where we want them? There was even more kind of differences in the knowledge questions. So right now it's just a tool we use one time, but maybe over time there would be a ability to use this tool as a quality measure. Where we use it 1 year, maybe the next year a hospital uses it again to see if their staff responses have changed. All right. The other kind of idea for in-hospital improvement work is family reported measures. Most of the measures that I've shown you that are published that you guys are looking at, these are measures that we get from the chart. Some of them are family-centered measures, right? Rooming in, breast milk. But how about measures that families tell us? Like, were they satisfied with the care that week? Did they get to visit the hospital as much as they wanted to? Did they get to meet with their doc as much as they wanted to, or their nurse? Did they feel respected? I know the CPQCC, your state collaborative, is working on a broader project to start building family reported measures into their NICU improvement work. Hopefully you guys are also looking at ways to include these in your NAS work, where we're trying to as well. We're still pretty early, but it seems like all of us should have some mechanism to ask families themselves on how the care is going during the hospitalization to really assess in-hospital care. All right, I'm gonna go a little faster just because I think I'm taking a little too much time. Although Fifi, you saved me a few minutes, which I appreciate. All right, claim 3. So claim 1, we're doing a pretty good job of improving in-hospital care. Claim 2, there's even more we can do around in-hospital care. Claim 3, we're making some progress in improving care of women with opioid use disorder during pregnancy, but this is hard. I don't know how many OBs are on the call here. We have a very active OB kind of group in our collaborative as well, and they're the ones who are really working on this. But this is hard. Hopefully people know that if you are working on this part, AIM, the Alliance for Innovation in Maternal Health, this is kind of a collaboration with ACOG and some federal agencies. They put together a bundle or a toolkit that focuses on the obstetric care of women with opioid use disorder. And this is important because this gives us a framework for potential QI work. In particular, it gives us some anchors to target with measures. And you can't read this, it's pretty small, but I'm gonna blow up this middle one. So 2 of their kind of bundle elements, recognition and response. And you can see these are things that you could measure. So screen all pregnant women for substance use. I think that's one of your measures as well. Screen all pregnant women with a history of substance use for other comorbidities that might be real important. And then this ESPER, develop a brief intervention referral pathway that these moms, once you identify them, you can get them referred to treatment quickly. Identify a lead coordinator to ensure that all women with opioid use disorder have an individualized plan of care, right? So numerous centers have shown this, that if you put together or put in a caseworker, a social worker, a case manager to really coordinate care for these moms, you develop this integrated care model that's critical. A lot of places in Massachusetts are actually using peer mentor moms for this role, which is incredible. Their results have been dramatic. And then postpartum, make sure you're thinking about at least postpartum contraceptive services, and then referrals to address comorbidities when necessary. So the Illinois Collaborative took this framework and they developed measures that they are using, much like our hospital-based measures. So these measures speak back to care during pregnancy. Was mom receiving MAT? We're collecting that. But was she connected to behavioral health and recovery services? Was Narcan counseling documented? Was contraception counseling documented? At discharge, did mom have follow-up OUD appointments scheduled? And did she have a navigator coordinating follow-up services in the postpartum period? This is just a handful of the measures they have, but they have an OB data form and then a neonatal data form. At least in Massachusetts, currently our hospital-based data form is more like their neonatal data form. We want to start working towards more of these mother-focused measures, particularly measures that speak to pregnancy. Now, one challenge there is that getting data during pregnancy is largely outpatient data, right? It's from OB clinics, OBs in their clinics. And PQCs, like Susan alluded to, we're largely hospital-based collaboratives. Our members are our hospitals, and we have systems set up to get data from hospitals, data use agreements, whatever we need. It's much harder to do that for outpatient OB providers. So what Illinois did, which is similar to what we're pursuing, is pretty cool. So they said, look, it's gonna be hard for us to get patient level data from clinics, but we can get aggregate data. So they're asking clinics to audit 10 births a month and then go back and look at those charts for 10 births a month and see, was OUD screening during prenatal care documented, and then was OUD screening during L&D documented. And then they just send into ILPQC the aggregate data for these 10 audited charts. So it's a sampling strategy and aggregate data, not as great as patient level data for all patients involved, but at least this gives you some kind of system for getting some data in the upstream outpatient OB area. All right, claim 4, increasing treatment for pregnant women with opioid use disorder may be the most important improvement we can make. So we've been focusing on non-farm care, improving that hospital-based care, which is great. But if we kind of focus on this upstream part, improving care of the pregnant woman, probably this is going to be the most important intervention we can make. So it really highlights that our collaboration with our OB collaboratives is critical. If mothers are engaged in treatment on MOUD when necessary, that's going to be the most long-term impact on outcomes for these families. I'm not going to go into why this is true. I think there's ample data that shows that mothers with opioid use disorder who are in treatment have the best outcomes both for themselves and for their babies. So this is more to highlight that we do need to focus on this upstream part, maybe even more than we are. One challenge that is, and this, I've heard this a few times, is if one of our goals is to get more and more of these mothers with opioid use disorder screened, identified, and onto medication therapy, which is still the cornerstone, won't that result in more babies with NAS? So is that really the goal we want to pursue? And one challenge here is that we still don't know too much about long-term outcomes of NAS. I'm not going to get into this literature for time, that there is some literature on this now. But overall, I would say that my interpretation of literature is that what we do know suggests that in utero opioid exposure, particularly when it's MAT or MOUD, is going to have limited effects on long-term outcomes for the baby and the child. And more, it's the social factors that play a far greater role in determining growth and development. So the best data out there suggests that mothers who are on medication therapy for opioid disorder, their babies have the same developmental outcomes as non-opioid exposed newborns. To me, that's the best data that's out there. The other reason this is important to think about is if mothers are on medication therapy for opioid use disorder, the severity of NAS might actually be higher. So this is some analysis that we've done in our state that looks at the odds of requiring pharm therapy based upon different exposures. So among all babies who are opioid exposed, did they get pharm therapy? Did they not get pharm therapy? If they needed pharm therapy, what are predictors of needing pharm therapy? You can see in this area here, the reference, illicit drugs without MAT and MAT and illicit drugs. The comparison group is mothers who were on MAT. Illicit drugs without MAT actually has a lower odds of needing pharm therapy. And if pharm therapy is a measure of NAS severity, that suggests that MAT compared to illicit use has a higher severity, a chance of a higher severity of NAS. If you think about it, that might make sense biologically, where medication therapy is going to be more consistent. The fetal exposure is going to be more consistent. So the chance of withdrawal might be higher. Reassuringly, we did see other things are protective. Rooming in, much lower odds of needing pharm therapy. Skin to skin, breast milk use, strong trends towards less likelihood of needing farm therapy. All right, and just to drive home this point, the Davida Schiff from our state and Stephen Patrick, they published a couple years ago a comment that included this statement. So efforts to expand treatment options, including opioid agonist therapy for pregnant women with opioid use disorder, with methadone, with buprenorphine, may in fact increase the number of cases of NAS, but they should still be considered a treatment success. And I think we as PQCs need to kind of own this, acknowledge that this might result in more babies with NAS. Maybe it'll even result in more babies needing farm therapy, but that's okay. In some ways, NAS in this case is almost a good outcome. All right, claim 5. So now I'm going to turn to the post-discharge. And here I'm going to state that improving care of mother and newborn after discharge remains a weak area. Fifi mentioned a lot of our work around EI. You know, you probably saw your publication in Hospital Pediatrics. It had a commentary that went with it. And overall, this commentary was very complimentary. It really liked your work and the importance of it. But they did acknowledge the most notable limitation of this work, this is your work, is the absence of post-discharge outcomes, including but not limited to hospital readmissions. Same criticism of Massachusetts work. So how do we deal with this? So one way we're trying to in the state, Fifi mentioned this dashboard that the state put together. So this is using population level administrative data to look at some outcomes. Here's the data. She showed it to you in a bit of a different format, but if you go to the website, this is what it looks like. This is our EI data. So EI referral from 13 to 17 has increased 55% up to 70%. EI enrollment, some trends towards improvement as well, 35 to about 40. This is among babies with a diagnosis of NAS. The challenge here, this is great, this is population level data, it shows us trends, but the latest from 2017, I think the 2018 data is about to be uploaded or will be very soon. So useful, but not in quite the timely way that we need. But through this, they also are looking at readmissions. So this is among babies with a diagnosis of NAS, what percent were readmitted within 6 months of birth to the hospital? 11, 12%, you know, maybe a trend downwards, probably not just yet. This is great, a good starting point. We need to make this now part of our QI work. Figure out how to get readmission data in real time and start looking at it and trending it. And then the other part about the post-discharge, and this is where I'm going to wrap up, is how about primary care providers or general pediatricians? Here, like meaning where I am sitting right now, in Massachusetts, we've done some efforts to reach out to this community, but not enough, not nearly enough. And certainly we haven't engaged them in our project. I'm not sure what the situation is in Colorado. I'd love to hear if you guys have pediatricians working with you. Susan mentioned that you at least have a measure of a warm handoff to a primary care provider at discharge. We don't have that. We want to add some better discharge prep measures, but it seems we need to get primary care providers and pediatricians involved to get a sense of what's happening at 3 to 6 months, both for the care of the baby, but we know that pediatricians are also critical to helping high-risk mothers in the post-discharge period. These mothers will see the pediatricians. They may not see their OBs. We know this, right? So the pediatricians can play an important role in making sure these mothers are still hooked into their services. You may know AAP is starting some work in this area. They started what's called they're using the ECHO platform for an improvement series around maternal infant health and opioid use. Interestingly, early in this process, the AAP decided that their targets would be general pediatricians and primary care providers, which is terrific. They are building some tools for PQCs for hospital-based care, but this particular ECHO series is going to focus on primary care clinics seeing infants who were opioid exposed. They actually launched this in January, February of this year, but then they put it on hold because of COVID. So they are looking to return to this. I don't know if they have a plan yet for when they're going to return to this, but when they do, I'm sure they'll send out broad communications, and hopefully this is something that all PQCs make available to our pediatric colleagues. And maybe this is a way of getting our pediatricians in our area to be engaged with our project. As part of this, they did develop some measures for pediatric care. I'll say the measures are good. I don't know if they're awesome, but the measures that they have, this is just a few of them. You know, is there documentation in the infant chart of whether or not there was prenatal exposure? At each visit, do the pediatricians screen for parental concerns around housing, food security, substance use? Are parents referred to community resources when the screening identifies a concern? And then EI referral, as Fifi has already talked about, as well as developmental surveillance of the infant. One other thing about post-discharge, we've been working with our Head Start community in Massachusetts to kind of incorporate referral to and enrollment in Head Start as an improvement goal. EI, we've heard quite a bit about. Early Head Start is a program for families who meet certain income and poverty requirements, but they provide really wraparound services for these families that are eligible. It started off as an educational system, but now it includes housing aids, food aids, social work aids, like really comprehensive services. So Head Start has committed to being part of the response to families impacted by perinatal opioid use. I'll let you read the statement here. But they acknowledge that the best outcomes are going to be when we have family-centered comprehensive care approaches, and that's what Head Start is meant to do. So we've partnered with Head Start. We've spread kind of Head Start information to our collaboratives. We've encouraged hospitals to do referrals to Head Start when these families qualify. We need to do some more work in this. We need to start measuring this, and we need to make it even easier for hospitals to refer to Head Start when they want to. I think pediatricians know how to do this, but not so much hospital-based teams. Kind of similar. We want to make it similar to EI. You're thinking about discharge, you're thinking about EI, think about Head Start as well. All right, and then finally, Susan already mentioned it this morning, Fifi mentioned this as well. PQCs do need to consider race and racism in all of their projects, and you guys have been leaders in this. But this includes perinatal opioid use. Susan showed some of your data. I'll just show some of the data we've looked at. This is going to be published soon. So we're looking at Black, Hispanic, white, so opiate exposures during pregnancy. And we saw in our data some significant differences. That white women had higher rates of MOUD alone, medication for opioid use disorder, and any MOUD, and lower rates of non-prescribed opioids. So Black and Hispanic women had lower rates of MAT or MOUD and higher rates of non-prescribed opioids. And when we did a logistic regression analysis, it was pretty interesting. This one, all the referents are white here. So MOUD remains significantly associated. This is an adjusted logistic regression models with quite a bit lower odds of MOUD. All the other outcomes, though, we didn't see a difference. So farm treatment, rooming in, breast milk, EI referral, discharge with biologic family. I know Susan showed some data that suggested maybe some differences in some of these for Hispanic women versus white women in your state, but we did not see that, which to us is kind of interesting. It suggests that if there really is a barrier to care, it may be at the engagement phase. If we can get these moms engaged in care, then once they're in the hospital, the other outcomes are similar. Then their involvement, our approach to them seems pretty similar. So something we're still working on fleshing out. We're going to do some qualitative work to see if mothers agree that there's some barriers to getting engaged in treatment during pregnancy. All right, so where can we go? Think more about family-centered measures, including family-reported measures. Keep focusing on getting pregnant women screened and in treatment, knowing that this is hard with our typical PQC structure where we focus on hospital-based teams and not so much on outpatient teams. You get the EI community engaged if it's not already, and early Head Start. Fifi mentioned that we're seeing a 70% referral rate to EI at hospital discharge. It feels like that should be higher, 80, 90%. I did notice that your data is around 40, 50% for EI referrals. So it seems like there's an opportunity there. Do our best to measure readmissions. We got to think hard about this. The increased efforts to get pediatric primary care providers involved. I'd love to hear what you guys are doing in this area. It might be that you're already making some more progress than we have. And then finally, look hard at potential barriers to care for families of color in this space. Awesome. So I know you guys are doing a ton of work in this area. We learned a lot from you already. Thank you for all you do for moms and their families. You rock. You rule.
Thanks so much, Munish. So much to learn. This is awesome. Massachusetts is always so ahead of the curve. So let's open it up for questions. We've got a good 15 minutes for a Q&A session. So feel free to unmute yourselves or chat in a question and I will read it out loud. And so while folks are thinking, let me start off. So the first comment that I have is around this finding that mothers that compared to mothers who are receiving MAT, those that are receiving or on MAT as well as illicit drugs, or potentially illicit alone, their infants are less likely to receive farm therapy. So that kind of tells me that we, at least in Colorado, should follow use of illicit or MAT plus illicit over time, because I wonder if that's in fact driving our lower percentage of farm use. That was just sort of a side thought, which kind of horrified me for a minute. More to the questions. So for EI, you know, here in Colorado, we are struggling with whether or not EI is the appropriate public health entity to engage with these families and infants over time. So, you know, we have much more restrictive EI eligibility guidelines than Massachusetts. And I think the folks on from the EI group are on this call right now, but, you know, they're wondering, is EI the most financially viable way to provide services for this family? You know, yes, they are sort of really important around developmental follow-up and provision of care, but are there other entities that could engage families around parenting and education that are more financially viable in the long run? And just wondering if Massachusetts has had those sorts of conversations.
So let me start by saying that there are a lot of other programs that could be used for post-judicial care for mothers and infants, but a lot of them are not statewide.
Fifi, could you go a little closer to your microphone? Sorry.
Oh, you can hear me. I was saying that while there are a lot of programs that we can refer mothers and children to, most of them are not statewide. They are in different communities, or such as home visiting. They don't address the problem at the state level, and we don't want that. EI being a program that is implemented across the state, like I mentioned, there is no geographic restrictions. It is viewed as the best way to look at population health. And the good news about EI is also, as they are a program that will allow the kid to transition to the school system. There is a good relationship between EI and the school system, where when kids age out of EI, they can be sort of handed out to the school system with early education or special aid. That connection exists, and it will allow you to follow the kids and see if EI will make a difference in school performance, in school outcomes later in life. That is, if you are allowed to do the linkages, which we are now doing in Massachusetts through by passing legislation, because the EI is on the FERPA, and similar to the educational system, but there are other legal restrictions in data sharing. But this is one way where you can follow the kids from birth, where EI is already linked to the birth certificate. You know everything that happened during pregnancy, around the time of birth, and EI and the school system is a way to look at the kids longitudinally over time. I think it might be expensive, but it's also the best way to do it. The other programs are just not statewide, and we've been complaining about that. Does that make sense?
Yes, it does.
Yeah, I have nothing to add to what Fifi said, other than just, I'm pretty excited about this early head start as an additional resource. Like, that's clearly only for a subset of these families that would be eligible. But at least in Massachusetts, our early head start community said that they do have the capacity to see these families, and they want to. You know, how available it is, we know much less about early head start in this population. Like, you know, our family's excited for early head start. Do they know what it is? Will they go if we get them referrals? But at least on paper, early head start has some additional resources that EI doesn't quite have in terms of kind of some wraparound services. Plus, by targeting kind of the higher need families, you know, maybe that would be a good supplement. But if you got to focus on one, I think EI is the one, given what Fifi mentioned, all those advantages. But if families have capacity for a couple, you know, maybe early head start's a good thing to explore as well.
Yeah, early head start is another program that is good, but the difference between EI and early head start is that there is a lot of backlog it's not, when you refer kids to early Head Start, they wait a long time to be, it's not as good as it seems.
Okay,
Yeah,
as
it
they
is
say.
better. And we do have more funding. Massachusetts puts a lot of state funding to match the federal funding we get for EI. So we're talking millions of dollars and a lot of commitment on the part of the Department of Public Health and other state agencies to support EI services. So I think as expensive as it seems, it's also what we have now. It's the best we have now.
We have a comment here from Meg Kirkley, neonatologist at Denver Health, which is our safety net hospital here in Denver. And she says, I feel like we definitely see a higher risk of infants needing farm therapy when mothers are on well-established MAT compared to those who use illicit opioids alone. I wonder if those who do antenatal counseling are preparing mothers for this. And anecdotally, she said she's also noted the association with concurrent SSRI use.
Yeah, it's a great point. And this is and it kind of, you brought this up initially, Susan. I can't imagine that your decrease in farm therapy is because you're seeing more moms with illicit opioid use. I think you showed your numbers and that's pretty flat at least. But the it is important, right? If we're going to get more moms on MAT, which again, we know that in the big picture, that's probably the most important thing we can do. We might as a community need to stop thinking of NAS as this bad outcome, right? Like, and almost start viewing it as an acceptable outcome that's part of this process of getting these moms engaged. And that goes into antenatal counseling. It goes into what our OBs say and all of us say. But I think that result is in multiple studies now. Like if you look at multiple different studies, it shows that maternal MAT use does seem to be associated with higher severity of NAS. So I think it does prompt us to change the way we think about it.
We have a question here from Kaylin Klee, who's one of our addiction medicine specialists in our state. She says, thank you for a wonderful presentation. Could you please comment on any initiatives for residential treatment for women and children, sober housing options, or family-based residential programs? For many of my patients, unstable housing is one of the largest risk factors for loss of custody, relapse to use, or loss to follow-up.
Yeah, I can comment on where that's come up in our collaborative. Like obviously this is so kind of local and context dependent, and even to the point where it's been hard for us to do anything about this as a state collaborative. And Fifi might have some other comments, but regionally in communities, locally in certain counties, I think people have developed pretty innovative approaches to try to offer kind of residential counseling, housing, address these issues. It's been harder for us to do as a state collaborative because it does seem to be so dependent on that local community and what the systems are in place. We hear about them at our state meetings, and maybe one county has come up with something that another county can take an idea from, but it's been harder to think of state level interventions in these areas.
Yeah, the only program we have is the Bureau of Substance Addiction Programs at the Mass DPH, which is funded through SAMHSA, that provides residential treatment and support through pregnant women in Massachusetts. Pregnant women are a high priority. They have higher priority than any other populations in Massachusetts with regard to receiving residential treatment and services from BSAS. So we do prioritize them, but we also recognize that we don't have enough capacity. There is a little bit of backlog, but also there are a lot of differences by race ethnicity in terms of who get those services. What we understand from the BSAS program is that sometimes the location of the services for some of these women of color is not just the right place, because if you're a woman of color, you live in a Roxbury area, Mattapan, and your services are located in a wealthy neighborhood like Newton Wellesley, you're less likely to go. So there is still a lot of work to be done around how the services are distributed throughout the state and how access is limited for people of color, particularly Black, non-Hispanic, and Hispanics.
Right. Question for both of you. Munish, you had shared some of the work being done in Illinois and how they're getting aggregate data for some of their measures. And yet, I think all the PQCs are trying to adopt an equity framework where data really needs to be disaggregated. But clearly we understand that the data burden for hospitals is real. So I was wondering for both of you how you're kind of dealing with that in your projects. The need for individual level, patient level data, truly if you're doing equity work versus the data burden on hospitals, and that it's so much easier, yes, to give monthly aggregate data to the PQC versus pulling data at the individual level.
Yeah,
So
I mean, Susan, you'll figure this out before we do. Yeah, I think for the hospital measures, it works, right? Like we can get data use agreements with hospitals that let us share patient level data. But if you're looking for data from OB clinics or from pediatric clinics, I'm not quite sure how we're going to do that. The OB data, at least, you could get it from the hospital record, right? You could say, all right, but at the time of delivery, we're going to go back and look at the prenatal record that's part of the hospital record and see if mom was screened at first prenatal visit, if she was screened at 18 weeks or 28 weeks or whatever the timeframes are. But not always is a full prenatal record in the hospital record. And if you want to do it in real time, like, this month among all your new patients to your clinic, did you screen them? You have to make these agreements with those OB clinics. So I don't know of any PQC that successfully navigated data use agreements with outpatient clinics. Maybe with clinics that are part of a hospital system, but not with kind of a range of clinic formats. So hence this audit, all right, go audit 10 charts and give us the aggregate, but you lose, a lot of powerful information, just like you said. I don't know what we're going to do with pediatricians. So this AAP ECHO project is again using audit and aggregate. So they're saying that these pediatric practices take a look at 10, 20 charts of infant 6 month or under and send us the aggregate, but you lose the patient level. So something for us as a PQC community to work on.
So as a part of our AIM project, we are using hospital discharge data for the 22 hospitals that are participating in AIM, and we are stratifying those data by race ethnicity. But the challenge is there is missing data in the hospital discharge record. And what we've done is after we provide the data to the hospital, we meet with them virtually or in person to discuss their data findings and show them where the gaps are. And we've been asking hospitals to fill in the gaps. We actually met last week with UMass because what happens is the data wouldn't be available in the hospital discharge record, but it would be part of the medical record and it would be part of the delivery record and the birth certificate within the hospital. There is a gap between existing data and data that get transmitted to the custodian of the hospital discharge record. So we've been trying to tell them if they want the data to be run through the hospital discharge for their AIM measures, they need to be sure that transmission data is not lost during transmission. They should transmit everything that is related to race ethnicity because they do collect it. And we are beginning to do quality improvement around data collection at the hospital level, working directly with them. And in fact, we just received an NIH grant to work on health disparities, maternal health disparities, and we are specifically targeting some of these hospitals around data collection, which will ultimately improve our data collection at the state level if all hospitals are willing to consider collecting race ethnicity, but also the social determinants of health, because it's easy to collect. They are available and they can be part of the medical record. So we're kind of working on both ends to be sure that over time we will improve our data collection.
It's really exciting. Well, we're going to have to bring you guys back next year to share what you've done in that arena, because I think this issue of sort of data, missing data, particularly around race, ethnicity, social determinants, continues to be a barrier for our PQC that we're actively working on. Well, thank you, both of you, for your time and your participation. Always amazing to hear what Massachusetts is up to.
Thank you for inviting us. And Jamie, yes, we're still getting Susan back.
All right. All right.